Thank you very much to the organizers for inviting me to give this presentation here at this great meeting, which unfortunately is not going to happen in person this year. My name is Jan Claassen. I'm an associate professor of neurology and director of critical care neurology at Columbia University. I was asked today to talk in this part, talking on sedation, about electrophysiological monitoring in paralyzed patients. These are my disclosures. So importantly is my funding agencies, the NIDS, NIH, and foundation funding. I'm a minority shareholder at ICE Neurosystems, which does not really directly apply to this talk. So if we talk about sedating patients in the ICU, this is incredibly common throughout the world. We have to think about what are the challenges in guiding sedation in the ICU. In general anesthesia causes a reversible state of unconsciousness. Adequate sedation, however, is challenging to judge. We know this from the operating room, where rarely there can be a case of awareness during surgery, even though the patient received sedation. We know that particularly in paralyzed patients, as they cannot express with their motor with movements that they are conscious, it may be challenging to titrate exactly to the right amount that is required to cause unconsciousness, but not to oversedate. The goal would be to find the sweet spot in between under and over sedation. Under sedation may cause psychological trauma, what I just talked about. Self-extubation may be seen, aspiration, delirium. The patient may remove central lines, other things. Oversedation may be problematic because it's also been associated with causing delirium. Longer days of mechanical ventilation are a strong predictor of worse outcome, and it may cause hypotension depending on what agent is used. The required sedation level may be individually influenced by the age of the patient, renal hepatic function, by brain injury, by many other factors. And so finding the exact right level of sedation is not straightforward. Can the EEG help in this question? So I'll talk about this. Changes in the EEG with levels of sedation are predictable. So this is the hypothesis here. You can see here that in different states of anesthesia, there are changes that clearly can be seen from excitation here all the way down to burst suppression and isoelectric EEG, which you can actually generate. For example, of course, you can get it with coma or brain death, but you can also cause it with the severe high doses of barbiturates. So the EEG changes with sedation. However, is that the only way that the EEG changes? So EEG is sensitive, but not very specific. So brain perfusion can also cause changes in the EEG. You can see here along this spectrum of dropping brain perfusion that the EEG also changes, similarly to those changes seen with sedation in a predictable way. ICP hydrocephalus can cause changes in the EEG. Focal injuries, strokes, bleeds, any of those, cardiac arrest, hypoxia can cause changes in the EEG, and seizures can cause changes in the EEG. So it's not specific, but it's highly sensitive. In summary, EEG reflects neuronal activity. EEG is predictable, has predictable changes with increased sedation. What is the mechanism underlying this? So that's not completely understood yet, but quite a bit was worked out in patients with disorders of consciousness, with injury to the system, where it seems that with changes in the thalamocortical, so between the thalamus and the cortex, that connection, if that is changed to different degrees, if that is altered, impaired, then the EEG changes in a predictable way. This is the spectrogram, so slow frequencies are here and high frequencies are here. You can see that in completely dissociation between the cortex and the thalamus, it's very, very flat, and there's very little activity here. You can see slow frequencies with severe differentiation, and then in normal brain, you have like nice peaks here in the higher frequency ranges. So that might be underlying these changes. How can we analyze the EEG and utilize this in the ICU? So you can take the EEG, you can do a fast Fourier transform, which takes different frequencies in the EEG, slow frequencies and high frequencies. Here you can see that it breaks it down into slow and high frequencies. And then you can express this in color maps over time. So this is time. Here are slow frequencies, high frequencies, and the color indicates the power in these different frequency spectra. So you can see that something happened here. This, in this case, was a seizure, and you can see this easily on this spectrogram plot. You can analyze the EEG by spectral power. So here you can see that with different levels of anesthesia here, no anesthesia, and then deeper stages of anesthesia, you can see that the EEG power in the alpha frequency changes here. It relocates from the back of the brain in conscious patients that are not under anesthesia to going to the front in patients that are anesthetized. You can look also at coherence, which basically just looks at how one electrode correlates with another electrode. And that can be displayed here in a nice color map, patient before anesthesia, going under, during anesthesia, emergence, and then the patient is emerged. You can see that the alpha coherence is first in the back of the brain, then relocates to the front of the brain, and then when the patient is re-emerged, is in the back of the brain again. So if you look at different anesthetics, the EEG spectrogram signature is specific to those anesthetics. Much of this work has been worked out by Emery Brown's group at MIT, and you can see here examples for propofol, for example, where the spectrogram plot shows especially delta and alpha oscillations. You can see that for sevoflurane, it looks slightly different. There's much more sort of this constant slow alpha, delta, and theta oscillations here. In ketamine, an NMDA inhibitor, it looks completely different. You have these high frequency oscillations here. And then last but not least, in Precedex dexmedetomidine, you can see that there are 9 to 15 hertz spindles. So this might be specific signatures depending on what kind of anesthetic you're using. This could be useful. So these specific signatures are based on anesthetics that are used, but confounders have to be accounted for: ischemia, hypoxia, ICP, seizures, and focal injury. Should EEG be used in the operating room? There's some meta-analyses and guidelines that have been developed. This is just by one big agency. They concluded that EEG monitoring should be considered as part of the vital organ monitors to guide anesthetic management, but anesthesiologists should be encouraged to be knowledgeable in basic EEG interpretation, such as raw waveform, spectrogram, and process indices. So meta-analyses support the use of the EEG in the OR, but it requires knowledge of waveforms. How about the ICU? It's not so much data on that yet. Very early on, EEG was already used in the critical care setting, mostly to guide barbiturate administration in patients that had elevation of ICP, for example, in a TBI patient. And here you can see an example. This was before the widely available use of direct ICP monitors. You can see that the spectrogram dramatically changes after barbiturate bolus is given. And you can even see how long it lasts. So this has been conceptually been used there. EEG does correlate with levels of consciousness. If you look at different analysis, this is, for example, alpha power, so just the power, the activity in the alpha frequency range, or the complexity of the signal, it's called theta permutation entropy. You can see that conscious to unconscious patients, even with brain injury, these were patients with subarachnoid hemorrhage, looked quite different. If you look at these indices and you predict the behavioral exam, the EEG is very accurate and potentially more accurate than just looking at the sedation level, the neuro exam, or other things. Does this translate to other conditions? So in this group, Jacobo Sitz's group in Paris, they looked at patients with chronic brain injury, and they found very, very similar patterns. So this may be generalizable beyond the acute or the subarachnoid hemorrhage setting. This is probably a phenomenon we can see in many conditions. So the ICU, in the ICU, EEG correlates with level of consciousness. Now going more focused on what I'm asked to talk about, EEG in paralyzed patients, neuromuscular blockade has no effect on consciousness or the EEG. It does abolish EMG activity. So in some studies, when you just look at quantitated EEG, like the BIS, you see a dramatic change when neuromuscular blockers are given, but that's probably just because the neuromuscular signal goes away. The EEG may be there for a good month for sedation. So I'll just show you some experience that we had early on in COVID. So this is just a recent publication in Lancet where we looked at the epidemiology. So 22% of critically ill COVID patients were critically ill. 70% required mechanical ventilation of those critically ill patients, and 25% required neuromuscular blockade. Assuring adequate sedation was particularly challenging in these patients because there was limited access to the patients. Many were paralyzed and some were prone. So using a very limited montage, just a frontal montage, we looked at just the EEG that we recorded from that, and just had the epileptologist say reduce sedation or maintain the sedation, did this, and looked 6 hours later how often we then had to go back up on sedation or had to change our management. Here's a quantitative analysis of that, and we did find in these patients that only 12% of patients that were recommended to lower the sedation, we needed to go back up on sedation. So the EEG, this is just very early evidence, but suggestive that the EEG could be used to guide sedation in these patients. Can this be automated? When we looked at quantitative EEG and not having the epileptologist look at it, the quantitative EEG easily separates the patients that have excessive versus those that have adequate sedation. So we may not need to bother an epileptologist, and if this can be automated in a simple way, this may be more applicable throughout the world. This automation has been shown to in other settings. So EEG-based tracking of the level of consciousness and delirium has been proposed by this group, and it seemed to correlate quite well with RAS scores. And this group from Brandon Westover from MGH, they actually had a mouse model where they had the EEG analysis guide a pump administrating the medication, and thereby just automatically sedating the mouse. So could this be in the future a closed loop where the EEG directly guides the administration of medication? Again, many obstacles before we would do this. And we have to look at confounders first. The BIS is a quantitative measure that reflects mostly in these cases, reflects also muscle activity. That's a big concern. Neuromuscular blockade without sedation had been given in one study here in 11 healthy volunteers, and it caused a dramatic fall in BIS. So just using that to guide our therapy might be dangerous. In the ICU, there's huge variability of BIS numbers, so that might not be the answer, but the potential is there. So last but not least, EEG-guided sedation may be feasible in paralyzed ICU patients and could be optimized. Thank you very much for your